there is a mild perivascular infiltrate. So all these cells are of two types, predominantly neutrophils, the smaller ones, and some admixed eosinophils, these ones with very bright cytoplasm. Similarly here, the epidermal lesion shows a few inflammatory cells. And beneath the bulla or the vesicle, what we see is lots of these inflammatory cells, which are an admixture of neutrophils and eosinophils. And then lower down, some perivascular inflammation, lymphocytes, neutrophils, and eosinophils. If we focus on this area, we see that the nuclei of these inflammatory cells are fragmented. This is a process that goes by the name of leukocytosis. So the diagnosis is dermatitis herpetiformis, confirmed on biopsy.
Since the diagnosis is confirmed, so drug of choice in this is dapsone. So one thing very important to point out is when we see a patient of dermatitis herpetiformis, we must look for celiac disease because 90% of the patients have associated gluten sensitivity, gluten sensitive enteropathy. So I said 90%. So this is a large number. So the moment I see DH, it is my responsibility, professional responsibility to look for the celiac disease, which may be asymptomatic. Then look for the thyroid involvement because half of the patients will have hyper or hypothyroid. Now, in these patients, if they get some fever, some joint pains, remember, non-steroidal anti-inflammatory drugs should not be given. Thank you very much. Now, the second case, which is very, very important and very interesting. So, this is the 40 years female who reports with asymptomatic firmopapules. So, these are the firmopapules. They are asymptomatic. Their number is about 15 and they are smooth surfaced and only on the scalp, nowhere else. It is now, you see, about 15 page numbers, and then they are persistent for more than 1.5 years, asymptomatic. So, no lymphadenopathy. So, my differential diagnosis was, am I dealing with cylindroma, adnexal tumor, angiosarcoma, neurofibroma? So, we took a biopsy from this lesion. You can see. So, this was the lesion which was biopsied.
So here is the biopsy, and the epidermis is normal. There's really not much here. But the dermis shows a very impressive infiltrate and some very prominent blood vessels. And all this is the infiltrate. And even when we look from a little distance, we can see that there are a lot of blood vessels that have proliferated in this lesion. Now, the infiltrate is composed mostly of lymphocytes. It is perivascular as well as goes between collagen bundles, which means it is interstitial. And the blood vessels here are mostly ectatic. And what is characteristic about some of these blood vessels is that the endothelium, that is the lining cells, are very prominent. They have plenty of cytoplasm, which is eosinophilic. Some of the cells, that is the endothelial cells, show lumina within the cytoplasm, which resembles small blood vessels. And here's another lumen. And these lining endothelial cells seem to protrude into the lumen of the blood vessel. So this is the lumen which has these red blood cells. So this finding is very characteristic in this lesion, finding of blood vessels with all these features. And now to focus on the infiltrate, among the lymphocytes, you see these admixed cells with bilobed nuclei and very pink cytoplasm. These are all eosinophils. So we have lymphocytes and eosinophils, which form the infiltrate. Here again, another field showing lots of eosinophils, all these cells with very pink cytoplasm. Now this looks like the spectacles of Gandhiji. See these lobes? This is one lobe and this is the second lobe. These are eosinophils. And so the diagnosis is angilymphoid hyperplasia with eosinophilia because of the presence of so many eosinophils. And if the patient were a small child, we would have to rule out Kimura's disease. This is purely a histological differential diagnosis. Of course, here we have an elderly patient, but the point is that clinical pathological correlation is key to coming to the correct diagnosis.
Angiolymphoid hyperplasia with eosinophilia versus Kimura's disease. Angiolymphoid hyperplasia with eosinophilia is primarily an arteriovenous malformation in which there is secondary inflammation, whereas Kimura's disease is primarily an inflammatory process in which the vascular proliferation is secondary. So, clinical pathological correlation will make the final diagnosis. Second, angiolymphoid hyperplasia with eosinophilia. The lesions will be non-tender papules and nodules on the scalp and the neck with no lymphadenopathy. Whereas in Kimura's disease, the lesions will be subcutaneous. They will be non-tender. No, these are the nodules on the head and neck region, but there will be lymphadenopathy. See the contrast? No lymphadenopathy, lymphadenopathy. Subcutaneous and lesions on the dermal lesions. Now, 20% of the patients will have eosinophilia, whereas IgE levels are normal. Whereas in Kimura's disease, 100% patients will have eosinophilia and 100% patients will have raised IgE levels. No comorbidity. 20% will have renal disease in Kimura's disease. This is usually a reactive process triggered by an infection or trauma, whereas Kimura's disease is an autoimmune phenomena triggered by an infection or a toxin. Angiolymphoid hyperplasia with eosinophilia is an unusual reactive vasoproliferative process which is an uncommon idiopathic condition of adults, probably triggered by insect bite, trauma, or infections. It is present as isolated grouped papules, plaques, or nodules, and the lesions are usually less than 3 centimeter in size. These are asymptomatic, may be pruritic, may be painful. Head and neck is the most common area affected. It is benign. Peripheral eosinophilia is seen in about 20% of the patients. Serious complications do not occur in these patients, but they persist for years and is difficult to treat. Now, so there are so many treatments done: topical steroids, intralesional steroids, systemic corticosteroids, methotrexate, electrocauteries, antibiotics, carbon dioxide laser, topical antibiotics, isotretinoin, dapsone, radiotherapy, imiquimod, oral propranolol, but nothing works because it is the vasoproliferative disease. Only the surgery will work in these patients. So surgical excision that includes both arterial and venous segments at the base of the lesion is desirable. Thank you very much. So any questions? Any questions? Hello? Any questions?
Sir, I dropped a message in the chat box.
Okay. So there is a question about tofacitinib. Am I right? From
Yes,
Dr. Akash Sarkar. So he's asking that what are the complications of tofacitinib for long-term use if patients take without any advice? Now the answer is thromboembolic phenomena, and the other is reactivation of latent tuberculosis. These are the two major concerns. So patient has to be definitely guided before prescribing that don't self-medicate. So he has to be under the uh, proper evaluation and supervision. Any other question?
That's all, sir. All queries are answered.
Okay. So should we
Thank
close
you,
down?
sir, once again.
Right.
Yes, sir. These two cases was really, I think very new one, and our spectator are already seen it, sir, and your judgment also they have seen both of your talk. Thank you once again, sir, for associating with us and giving this opportunity to live stream your program. Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you, ma'am. Thank you, sir.
Okay. Fine. Appreciate it. We leave
Thank
the
you, sir.
meeting.
Thank you.
Okay.
Yes, sir. Yes, sir. Thank you.
Okay.